All right. I am really honored today to introduce to you Tomiquia Moss, who is Secretary of Business, Consumer Services, and Housing for the state of California. In her role, Secretary Moss oversees California's efforts to prevent and end homelessness and to preserve and expand safe and affordable housing opportunities for all Californians. Our hope in bringing Secretary Moss here today is really to push forward the conversation started by the panel this morning and how we can use the tools of evidence and research to move into better and more evidence-informed policies. Prior to Secretary Moss's current appointment, she founded and led All Home, a Bay Area organization advancing regional solutions to homelessness. And she was CEO of Hamilton Families and Executive Director of the Hope SF Initiative. Secretary Moss is going to share her thoughts about research needed to support policy and action to address upstream determinants of health, such as housing and homelessness in California. Thank you, Secretary Moss, for being here with us today.
All right, well, good afternoon, everyone. How you holding up? It's 3:15 on a Monday, right? Well, hopefully this will be a lively discussion. I am really excited to be with you this afternoon, and thank you so much for such a kind introduction. I do have some slides I wanted to share, but before that, I wanted to talk a little bit about why research and data matter so much to me and to this work. So I've been in the Bay now for 21 years. Love brought me here, which is beautiful, and is still working. 21 years in, so really excited about that. And I have really tried to take a more holistic approach to how we support communities throughout the state of California, and particularly in the Bay Area prior to my state appointment. I started my work actually as a social worker in the Tenderloin, and I worked at the Tenderloin Neighborhood Development Corporation. Anybody know TNDC? Hey, 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 hey. And it was the first time I had started doing work with folks who were exiting homelessness, elders who were living in housing in our single-room occupancy hotels. Prior to that, I had been doing domestic violence work and work with young people. And it was the first time I started to understand how foundational housing was for folks, right? Like we talk about it as if it's, and frankly, our society functions because it's a commodity, but it is a foundational need to how people need to thrive in their lives. And it was so powerful to me. My office was a unit right next to where folks were living. And their lives were on display. And one of my primary responsibilities was to try to figure out how to keep folks housed. So at that time, folks were getting referred into the housing, but that housing stability was so critical for folks. And so it was such an important reference point for me in my career here in the Bay Area. And now I think about how vulnerable so many of our communities are because housing affordability is, I think, California's biggest threat. We have more than 3 million households across the state of California who are earning less than $35,000 a year and unable to afford their homes. We have 180,000 folks on any given night experiencing homelessness in the state of California. And so the crisis is urgent mostly for those most proximate to the problem, but it is also happening for college graduates who are finishing school and not being able to find apartments and homes for themselves in the state of California, living with family members, doubled and tripled up. And so it's a really exciting moment to me to figure out how to tell the story of how housing affordability is the issue of our time and how we can collectively bring our assets together to address this crisis. And I think research and data undergird our ability to tell that story. It animates what we all know about what is happening in terms of income inequality, in terms of the racialized nature of this challenge. And so it's really exciting to me to be with you all to talk a little bit about how I think research can help advance our work at the state. Now, let me see if I know how to advance these slides. Here we are. So, my agency, Business Consumer Services and Housing Agency, is a really unique agency. There's more than 7,000 folks under my leadership who work on our housing and state policy, our housing policy and our homelessness policy. But we also have more than 4 million people who are licensed professionals through my agency and businesses as well. So it's a really interesting sort of combination of how we think of our workforce and our economy, as well as our housing and affordability needs. So I find people often say, that's such a broad portfolio. And it is, but in some ways, it's a really great opportunity for us to look at the intersectional nature of our housing issues, our economy. How do we make sure that people have household incomes that they need in order to afford housing across the state of California? How do we make sure that the professions that we license represent the diversity of California? So those are some of the things I think about as I step into this role. I'm about 3 months in at this point. So we're doing it together. It's very exciting. We also oversee all of the regulations for financial services, credit unions, banks, making sure that consumer protections are primary to how Californians are being served across the state of California. We also, within my agency, is our civil rights department. How do we make sure that we are looking at fair housing and employment, making sure that we are not allowing discriminatory practices to persist across the state of California. So BCSH is quite a diverse portfolio, but I often say it touches virtually every Californian in the state. So I'm really honored to be leading this work at this time for a governor who I think has demonstrated a commitment, particularly to housing and homelessness, unlike any governor over the last many decades. Unprecedented investments, but how do we make sure that those investments translate to improving lives in communities? And so that's the work ahead of us. So I wanted to talk a little bit about, I know my colleague and friend, Dr. Kushel, spoke earlier about her statewide study. There's tons of incredible research partners that we've worked with over the years, the Turner Center, UCLA Policy Lab doing some really incredible work around homelessness prevention. But I wanted to share some of the things that we're doing at the state. Just last week, the governor and I introduced the sort of blending of our housing and homelessness work into what we're calling HARP, which you see here on the screen. We established a housing accountability unit within the Housing and Community Development Department in my agency. And it was really to make sure that jurisdictions were doing their fair share around planning and building enough affordable housing for the community. And through that program, paired with our Surplus Lands Act, lots of acronyms, y'all, I'm doing my best, that has unlocked more than 20,000 units of housing just in a few years, right? That otherwise wouldn't have become available for affordable housing in communities across the state. So we're taking that work a step further, and we are shifting. The HAP program, which is the primary source of funding for statewide support around homelessness, is transitioning into that unit. And so we're going to be able to track our investments across our housing portfolio and those that are communities that are receiving our HAP funding, and making sure that we're not only tracking the resources, but we're working with local jurisdictions on setting goals to actually reduce unsheltered homelessness across their communities, right? When I think about research and data, as I said, I think it animates the work, but it's then using that information to set up policies and systems that actually make a difference on the ground. And so we're really excited for this integration and to work more deeply with local jurisdictions, providing that robust technical assistance, making sure that we are in sync with what our local communities are doing with respect to our resources. It's really important for me to think about this work from a human-centered perspective. So often we talk about resources as if they don't affect people's lives. It's the funding streams and whose money is purple and green. But what we really need to be thinking about is how do these resources actually advance the outcomes that we want to see in community. So I'm really excited about this work. We also have our Homelessness Data Integration System, or HDIS, that started just a few years ago. It's still a baby, but it takes all of our data from the continuums of care across the state of California and aggregates that data by individual. And so we are beginning to synthesize that information so that the departments and agencies on our Interagency Council for Homelessness can actually see where their resource is going. How many folks are actually exiting homelessness? How many folks are we preventing from experiencing the crisis in the first place? So I'm really excited to see our HDIS system grow and become a resource and tool for more systemic investments and outcomes that we want to see in our community. Let's see here. So when I think about the work you all do, it's really, really important that you are doing it with community. I can't say that enough. The statewide study, I think that Margot has done with her team, I think just up the game for how we not only talk about folks with lived experience, but we actually provide a way for those individuals to have their voices heard, for their priorities to actually be surfaced in the research methodology. And so I think that this is a critical component for the work I'm trying to do with my colleagues in the state to not only get the document, but have it be alive. How do we tell the stories and pick the messengers for the policymakers to understand what's actually happening for folks is a really important ingredient for the research approach that we want to use. The racial inequities that exist for folks experiencing homelessness and housing insecurity is profound. And we talk about it as if it's a data point, but unless we figure out why it's happening, how do we assess our programs to ensure that we are disrupting the disparities, then it doesn't go far enough. So I think it's really important for our research tools to unpack the sort of historic and persistent inequities that exist and talk about why they are happening and try to figure out what we can do collectively, both in our program design, in our resource allocation, to disrupt those disparities. I mentioned these two partners before. You know, when I was at All Home, homelessness prevention, targeted homelessness prevention is critically important. I know that many of you know that for every person that we house, 3 more folks become unhoused during the same period of time. So people often ask me, Tomiquia, how do we solve homelessness in the state of California? Well, we disrupt housing crisis for folks, thousands of people every single day. So we actually know what to do. But when you have the inflow into homelessness outpacing the exits into housing, it is a really difficult challenge to get ahead of. And so the work that the policy lab is doing with the predictive analytics, really trying to figure out what are the criteria and indicators that will help communities understand who is most at risk of homelessness, and putting your resources there, your legal resources, your housing navigation supports, and your financial assistance is critical to the solution set. So really exciting work that's happening down in LA. And then, of course, the Turner Center has done some work with All Home in helping to convey to folks who are people who are experiencing in the extremely low income category. We often talk about folks earning less than $35,000 a year for a household of 3. Well, we wanted to really help policymakers, the public, understand who those folks are, right? Like, numbers only go so far. It's your, bus driver. It is your in-home support services aide. It is the teacher's assistant. All of these folks in our community are struggling to make ends meet, and their housing costs are astronomical when their wages are stagnant and falling. And so it was really important to work with the Turner Center to sort of animate what ELI means and who we're talking about when we start to prioritize housing investments and workforce solutions for that particular community. Here we go. So, how can your research help inform us? I mentioned this earlier. I do think we talk a lot about concurrent investments at the state, where it's important that we create permanent housing for folks who are experiencing homelessness. But not everyone needs permanent supportive housing. A lot of folks need housing that they actually can afford. So we need to be thinking about what do those investments look like and customizing those interventions appropriately. We often talk about the need for interim housing. How do we bring folks off the streets quickly so that they can heal and begin to restore the dignity that was lost in their time on the streets, while we figure out how to build up that robust pipeline for permanent housing. And also prevention. We really think that prevention is a critical component to the solutions, and yet we have been in a scarcity mindset where we have to choose one intervention over the other. Well, that is not acceptable, and I know that resources are not infinite, but you have to make strategic investments and meet people where they are, or we're not going to be able to get ahead of this challenge at scale. So we really want to figure out how to support local communities with our state resources, guidance, and policy to make those concurrent investments. And so figuring out some of the inflow and outflow challenges that I talked about is one of the priorities that we're looking at. Figuring out how to leverage health investments, housing investments, transportation investments, climbing investments, right? Like, when you think about a holistic, healthy, thriving community, it is actually all of those things that people need. We don't want a porous social safety net, and people can't get family-sustaining jobs, right? Even if they have housing that they can afford, do they have the household income and opportunities that they deserve? So I think we're really trying to look at a more holistic view. So when I talk to the other secretaries across the administration, we are conspiring to figure out how to blend and braid some of our funding resources that have mutual policy goals. Our climate goals are our housing goals. Folks who are most at risk for extreme heat and extreme weather events are our most vulnerable communities. And so I've been on the job for 3 months, and every time somebody sees me, I'm like, oh yes, you also work for BCSH. So I feel like it is everybody's challenge, and housing is an all-state, all-hands issue that we have to address. And then lastly, I think about when you have to be choosing one intervention over the other, it's really difficult for local jurisdictions to invest in prevention. We've actually seen a really exciting opportunity for public-private partnerships. When I was at All Home, we were able to raise more than $25 million with philanthropy in the private sector to support prevention as a part of those concurrent investments. So how do we figure out how we can incentivize or help local communities put public dollars into prevention, because the inflow challenge is so critical in our work. And that's about it, y'all. So I really look forward to partnering with you. As I said, I am a research and data nerd, and I really want to use that as fodder to make really great policy investments and strategies for the state. So really look forward to our conversation and partnership. Appreciate it.
Thank you, Secretary Moss. Thanks for sharing your thoughts with us today, and I'm sure there'll be a lot of questions at the end of this next segment. So now it's my honor to introduce Suresh Gunasekaran, President and CEO of UCSF Health, to share his thoughts about the role of academic health centers in this work. As UCSF Health's Chief Executive, Suresh partners with UCSF and research enterprises to uphold UCSF's values and commitments to improve equity and social justice in the delivery of healthcare services. Welcome, Suresh.
Hey, good afternoon. That's a nice and lively crowd. I'm going to be a little bit challenged today. I don't do well with podiums. I like walking around, but I was thinking about what I was going to say today, and at its core, it's the real impact that clinical research and population health research can really have on the delivery of healthcare in America, because I think we all too often know the seriousness of the problems ahead of us. Many of us know the faces, many of us know the voices, and yet there are these substantive gaps. I've taken this job now 2 years ago at UCSF Health, and one of the things that I think will be the greatest challenge of my career will actually be addressing and solutioning around health disparities. When you look at the data, and you look at the history of academic medical centers, one of the things that you'll see at academic medical centers is that whether it was cardiology, whether it was neurology, whether it was transplant, we constantly started seeing that patients weren't having the same outcomes as one another. And what medical schools did over and over again is they subspecialized. They said, hey, the everyday neurologist can't do this. We got to have a very specific type of neurologist with a very specific type of training. And so if you look at this after 50 years across all of our medical schools, we are really, really, really good at subspecializing. And that has really reduced certain types of health disparities and improved certain types of health outcomes. But during that same time, the subspecialization at academic health centers hasn't solved other kinds of health disparities. Disparities in which your zip code matters, your access to basic food and social services matter, the color of your skin matters, your gender identification or other cultural characteristics matter. And yet what's ahead of us, for me, is optimism that if we were able to subspecialize within our health system to address certain types of clinical disparities, that we should be able to specialize and we should be able to innovate to address these broader health disparities. And it's that optimism with which I approach my work at UCSF Health. The good news is there are a lot of us. And amongst us, there are really great ideas about how to do this. But one thing we're really, really clear on is that the academic medical center of the past, and for that matter, even of the present, may not be the best configuration to have a huge community impact when it comes to health disparities. Because one thing we will tell you is we're extremely proud that if you need advanced neurosurgery, that regardless of your background, we will operate on you, and we will have great outcomes for you on the narrow corridor of that neurosurgery. But more broadly, your overall health, your overall wellness, being able to do complex neurosurgery doesn't help you with that. And so there are a couple of themes that as you think about your research and as you think about your collaboration, I just wanted to plant in front of you as things that we're thinking about at UCSF Health. I think number one is that we have to be in the communities that we serve. That the mere fact that the number one issue that many members of our community might have at receiving healthcare at UCSF Health is how long it takes them to travel here based on public transportation or other available transportation is our number one issue. And so when we think about what does the future of healthcare look like at an academic medical center, we got to move the ivory tower into an ivory network of health destinations that add to what the community already has. And that's the second piece. We can't do it alone. We think a lot about at academic medical centers that if you want to really subspecialize and you really want to do advanced neurosurgery, you got to control all the variables. Everybody in the building has to work for us. The facilities have to be configured a very specific way. We screen you, we do this stuff. And that subspecialization is really great for that when you control the variables. But when you want to have a broader community impact, you can't control all the variables. You got to work with the leaders that work on the front lines in those communities every day on the related issues, not just of health and wellness, but over housing, about workforce and job development and job training, education, food support. These are partners that are integral for us having the impact that we have. And don't get me wrong, in my sightline, our current chair and our former chair of family and community medicine, we have many, many leaders and many, many team members that are willing to partner and do that work. We have a critical role to play, but we can't play that role alone as we have in the past. The third thing that we think a lot about is what kinds of investments that we need to make. And what I would tell you is that we're thinking very differently about what the care team of the future looks like. Even though we are academic medical centers, largely centered around a very storied and powerful school of medicine, it's not going to be physicians alone, working alone, that are going to have the community impact that's necessary to address the disparities that we see in our communities. And it's obvious. And number one, we don't produce enough physicians to address the need. But leaving that issue aside, it takes a different role, it takes a different skill set. And I actually think probably the key competency we're trying to work on is listening. Because I think listening might be the capability that best allows us to address health disparities. I also think that your work is really instrumental. When I think about my role at UCSF Health, my dad, who's a PhD research scientist, always reminds me that I work on the boring side of UCSF, and that the real work is with the researchers who are not thinking about just the patients that are in front of them today, but all patients across America. And mostly I don't like to admit that my dad is right. But I will say that I do take in my job very seriously the ability to create an environment in which we can continuously learn to advance our research. And the specific area that I'm obsessed with is that we need to be better at measuring what work we do and the impact of the work that we do. And health systems are very well suited to do this work. We've just done a really poor job of using the assets that we have to do this. I'm lucky to work at an organization where there are leaders who ahead of me have already been working on this in various different pockets, whether it's around primary care, whether it's around chronic conditions, whether it's about hospital-based care or readmissions. We have worked to make measurement much better and provide the information necessary for today and tomorrow's researchers. But the challenge ahead of us is how to scale it up, how to do it across all of our services, whether it's in the primary care realm, whether it's in the hospital realm, or back in the community. And so these are the major themes that we're working on. But I will tell you, I just came from the Benioff Children's Hospital, and I was rounding, and I was talking to a family, and one of the things that they said, that I think they said it to me to make me feel better, was that they talked about how appreciative they were of the care that they got at UCSF, and how their child had been suffering with sickle cell and other related complications for many, many years, and that until they brought their child to Benioff Children's Hospital, they really hadn't seen the results that they had hoped for, and that they really feel that their kid is in a good place. But in the middle of when they were saying that, they said, I just never thought a place like UCSF would see us. And I thought you had to have a recommendation from someone to be able to get in here. And we didn't know the right person to ask for to get a recommendation. And I remember everything else this mom said. And I will tell you, the only thing that sticks with me is, if we're not making care accessible, we're not doing our job. And as excited and as optimistic as I am about our future, I'm a realist and saddened by some of our realities. And so when we think about healthcare disparities, if people have to think 3 times about who to get a recommendation from in order to get to the places that can help them, there's not much pride in being one of those places that can help people. So we're going to think very, very innovatively, and we're going to be very courageous in our attempts to change our own viewpoint, to be a little bit better, and to be a part of the solution. But a bigger part of the solution is your work, because there are so many different interventions that we could and should and might do, but resources, as was mentioned earlier, are not unlimited. We need to pursue the interventions that the evidence shows us work. And that's the most important thing that we can do, is to generate that evidence, and when that evidence is available, is use it. And at UCSF Health, we're really committed to doing that. And I appreciate your time today. Thanks for letting me give my brief perspective, and I guess we'll turn it over to the Q&A.
Thanks. I'm going to ask Dr. Jacoby to come up here as well. Is this working? Yes. Can you hear me? Thank you. Those were both terrific presentations of some of the challenges that we face. Earlier, Dr. Jacoby was talking about the services and resources of the Clinical and Translational Science Institute, and how that might interface with some of the clinical services that we're trying to provide at UCSF for the community, and also the policy and action agenda. So I just wanted to start off by giving Dr. Jacoby an opportunity to speak to that a little bit. Put you on the spot.
Okay, great. No, thank you. And thank you so much for your talks. That was really inspirational and wonderful to hear you incorporate in patient feedback to this event. Well, a couple things just really jumped out that I heard in this last half hour. I think a big thing that jumped out to me that Suresh was talking about sounded like what we call the learning health system. Right, so I really like how you amplified the role of research to impact care systems at UCSF by having evidence drive practice. And the learning health system is something we really think about a lot at CTSI and have a lot of support and are excited about amplifying more as we go forward, which is you highlighted how we have so many data assets at UCSF from all the care that we give, and how can we use that, do analysis, and then with that analysis drive improvements in our care. And that's what we call the learning health system. And it was really exciting to hear you talk about that. I was fangirling out in the back. I was like, Suresh Gunasekaran's talking about the learning health system. This is fantastic, because that is a really big area of focus for resources and services that we have at CTSI. So I think that's a great example.
Great. I had a question also about our clinical mission, and you talked about access to care at UCSF and how difficult it can be for patients to access our services. And often when we do research in the community, we're trying to engage with community health centers. And many times they're interested in participating with us, with our UCSF researchers, but they're also worried about us going in and doing research in their settings when they feel like the results of the research that happen in the community health center may not end up reaching them. They may not be able to receive the services that we have at UCSF that they're being provided through research. And I'm just curious to hear whether UCSF Health has a mission to engage more with publicly funded community health centers.
Yes, but I think that it will still be a less than engaging journey for us, because it's one in which we have so many deficits. And if you don't accept the deficits, it's hard to work through them. We are blessed to have a really good relationship with Zuckerberg San Francisco General Hospital and the health system therein. And there is so much meaningful work that is done through that channel and what our UCSF faculty do. But the question was about UCSF Health. And I think that for us, we have to recognize that we don't have the same infrastructure as the general, and that we have been historically oriented towards more of a referral practice. And it's that referral practice that has been overwhelmed. And it's not intentionally overwhelmed, it's just that we are good at what we do, and we have more patients trying to be seen with us than we have the ability to do. And we've thought about that in very traditional terms, and that's when we finally realized over the last several years that the problem is that we haven't gotten upstream. That was what I was supposed to talk about, but I forgot. As a traditional academic medical center, and when you focus on this specialization of that you are disproportionately unable to provide primary care services and basic secondary care services, and that's what the community mostly needs, at least initially. And the reason I say we won't immediately solve this is that these are not the kinds of problems you solve overnight, but you solve over a decade. And if we're talking about over a decade, we're really, really committed to doing it. And I think what's unique about this is that I think we have an opportunity, because we're late to the game, to go inside out. We are doing a community needs assessment to find those areas that are the least accessible and place our services there and test the hypothesis that people will find it more accessible in that neighborhood, but people will still come from outside that neighborhood to see us in that neighborhood too. And so we're really interested in changing our trajectory. And it's one that we plan around, and as you will hear more and more announcements, first in the city of San Francisco, how we'll try to cover the four corners of San Francisco, or maybe the more southern corners of San Francisco. Then I think that we will also talk a lot more about what we're doing in the city of Oakland. And I think these will be two areas in which over the next decade, people at UCSF Health will get bored saying, oh, here we go again, another project in Oakland, here we go again, another project in the city of San Francisco. We intend to be that kind of boring. And so I think that we are really excited about the future, but we need to be humble and learn from our colleagues at the General and others that do this well around the country.
Thank you so much. I have one question for Secretary Moss, and then I want to open up to the audience. But Secretary Moss, I was really impressed to hear how you have partnered with researchers at UCLA and Berkeley and UCSF, and Dr. Kushel, who told us earlier about how she has meetings with your staff every month and so forth. Amazing. And I am wondering whether you have advice for UCSF researchers who are beginning their work in wanting to affect health policy, and how do they gain access to policy leaders like yourself in a way that's going to be productive and fruitful?
Well, it's such a great question, because prior to joining the state family, I felt like it was a bit of a black box. I was like, who are those people? What do they do? There's so many of them. And so this question of access is actually one I think about often. I've been talking to my team about the public doesn't know what we do. Not just my agency, but we are so used to interacting on the local level. We see our mayors, our city council members, our boards of supervisors as the people who we bring our complaints to or our concerns to. But the fact of the matter is the state is often the engine that is funding funding programs in community, that are supporting nonprofit organizations in the work that they do in servicing our community. So part of what I think research does is it helps to tell the story about what's happening locally. And storytelling, I know I keep harping on this, but it's really important for policymakers and decision makers to understand their constituents, to understand the people who are impacted by the challenges that we're trying to solve. And research and evidence can bring that to life. And I think particularly under my leadership, I want to be able to bring those tools to our policymakers and say, look, this isn't a mystery. Right? We actually know what's going on. People are telling us what they need. We don't need to come up with new ideas. Let's actually just listen to the people that are informing what investments and resources and strategies we need to be taking up. So I feel like research is a tool, and then giving policymakers and decision makers permission to use those tools and tie it to outcomes and decision making is key. Because somehow you'll be in a hearing and then they'll be like, we should ask this question. But it's actually been asked and answered. We have researched it. So we're able to kind of bring the sort of tools back to the table so that folks can have them at their disposal when they're making those kinds of decisions in real time.
Thank you. I guess, but can a junior researcher just call your office and say, like, hey, I'm working on this issue, and can you
yes.
Can you?
And
I think people feel like they can't, so I'm just, yeah.
Yeah, no, I mean, really, like, I'm not being funny. Like, I didn't go to this job to sit in the ivory tower and wait for people to come to me. Part of what we have to do is take away the mystery. Government needs to be accessible for everyone. There's a lot of cynicism about government's role in solving social problems, but frankly, we know that if we're going to get to scale, local, state, federal government needs to be at the table. And unless we have willing partners that partner with UCSF and others to bring credibility to our work, we're not going to get there alone. So our door is open. My colleague Pedro Galvo is here from my office. Call us. We will put you in touch with the right people.
Thank you.
If you have good ideas.
Are there? Yes.
Can I just add a pitch for the impact program related to that? So that is such a kind offer, and a lot of people are writing down your mobile phone number. So that's really kind of you, Secretary. And just for if you are on a team, or if you are an early stage investigator or an investigator at any stage, CTSI Impact Program, who is sponsoring and supporting this event today, that is one of their key roles. So if you reach out to CTSI, if you go on the website and look for the Impact Program, they will provide you consultation, right? You're vigorously shaking your head. They will provide you consultation about next steps of how do we approach the Secretary with the appropriate data, information, and messaging to move our work into policy. So please reach out to them.
Right, and similarly, the CTSI has programs to help those of you who want to work with community health centers, who want to work with UCSF Health's affiliates doing research. We're working on opportunities for researchers to be able to carry out their research in those settings, including UCSF Health. So you don't have to call Suresh, you can call us. Questions from the audience? There's Scott Lilliger.
Is this on? Yeah, it's on. Yeah, hi. This is a question for Suresh from the UCSF side. I'm a long-term family physician working mostly in rural and underserved communities. I have a question about public-private partnerships because, you know, the bent of the meeting is really about healthcare disparities and access in communities that don't have the same kind of services. Thank you for the state of California looking at this, but I know there's a huge budget crisis, and I'm kind of wondering how the programs that were mentioned are going to be influenced. But at UCSF, I mean, other than having the two richest people around the planet put their names on Children's Hospital Oakland and on Zuckerberg, which is where I trained, has UCSF ever looked at public-private partnerships? Because a lot of the research benefits go to big pharma, medical projects, et cetera. Public-private partnerships that are specifically giving all of that massive amount of money that exists in other parts of healthcare that's not primary care. Because at the primary care level where I am in a clinic, you know, we're always frustrated. We don't have anything. If I look at the newspaper, I see UCS doesn't advertise primary care. It advertises all of its fancy surgical services, neurosurgery, interventional stuff. And of course, as you know, I graduated from UCSF. There are more people going into specialties into family medicine and primary care jobs. So I'm just curious whether UCSF as an institution has ever explored a public-private partnership that takes all of that millions and billions of dollars into actually giving money back to the primary care entities, including research.
Yeah, I think there are two answers to that question. Number one is that a lot of that happens today. And so UCSF has significant philanthropy and fundraising, and even for the one rich person that's here on the Children's Hospital, that family gave more money to research than they did to the Children's Hospital building and support programs in their interest area, which is pediatrics, but it includes primary care, it includes residency training, it includes subspecialty care, subspecialty research, I'm sorry. That same family is funding a huge research program in the microbiome and other areas. So I do want to say that one of the things that UCSF really does, and it comes straight down from the chancellor, is access significant philanthropic funds that exclusively get used for the teaching and research mission. And in fact, the majority of the fundraising of UCSF is directed towards the teaching and research mission and not patient care. And that's because these missions so rely on it, and because the philanthropists are so enthusiastic about putting their dollars where UCSF gets such great results. So I want to make sure that we highlight that. But then I want to get to your point, which is that should we be doing more for public-private partnerships in an area to meet the community's needs? And I think the answer is yes. I think that you probably saw in the paper, or maybe we weren't in the paper, that UCSF Health was trying to work with Madera Community Hospital in the Central Valley on a project that was specifically about addressing health disparities and other things, and it was a public-private partnership. But it was the kind of public-private partnership where UCSF Health was really putting up all of the money, not somebody else, not some third party, because quite often when you go to these communities, it's hard for us to find corporate partners that do that, but we were able to find a really awesome partner in the community that was willing to work with us. And so I think that's the future of what we need to do, is to make greater investments, but not make those investments alone. We should do, as you said, public-private partnerships where, if you can believe it, UCSF Health is the private part of it. And the public part of it is our community-based organizations. And at a certain level, you're just right. We need to do better at UCSF Health with or without public-private partnerships on primary care. I think that our future, our decade ahead of us, we're going to be measured not just by how well we do complex care, but how we do primary care. And so I think that whether it's with public or private partnerships or not, we are committed to increasing our investment in that. And when we say that, we mean that across all three missions. But the part that I own is substantially in expanding care. And I hope that we'll prove over time that we are serious about that. Thanks for the question. Really insightful.
Thank you. And we have another question over here.
Hi, it's me again. I'm Nancy Pope-Angulo, nurse manager, Pediatric Brain Center, Oakland and San Francisco. We talked a little bit about access, and I know there's so much data running in the background in Apex that I wonder if there's any research about an algorithm that pulls together some of the different social determinants of health in terms of who do they need to see. It takes people a while to get to San Francisco, but when we're here, if there's an algorithm that shows we need to see nutrition services, we need to see social services, and we need to look at housing, is there some way that pulls it together so that those things can happen in the one visit, and maybe it's a little bit of a half of a day or something, but that pulls that together? Because I know for neuro-oncology and pediatrics, when patients have had their surgery, they get to meet with neurosurgery, they get to meet with neurologists, they need to meet with the neuro-oncologist, they meet with the social services, and they meet with ophthalmology when they can. They meet with everybody during that time, and we just wrap around the patient. So I'm wondering how we could be a little bit more collaborative, and I don't know what insurance does for covering that, but that's just my mind, how AI might help with that. So just thoughts about our care model and what we can do.
Okay. I think that maybe we can broaden the question a little bit and also ask the Secretary her perspective on this, is that I think there's a technology component and then there's a community component. So I do think you're right that there's an opportunity for technology through AI and other things to identify the needs and the gaps. But many days it feels like the needs and the gaps are well identified, but they're overwhelming. This notion that we have in very specific areas like neuro-oncology, pediatric neuro-oncology, where we're able to do this wrapping around. We know when we do a community needs assessment that most kids don't need neuro-oncology services. And it might be helpful to let the Secretary talk a little bit about this, is that I think what we need to do is map this secret formula that we have for wrapping around things and find the right things to wrap them around. And I think that we need to start with the community and then bring our expertise. And I think that when the Secretary was presenting, we saw how much housing intersected so many of these things, but I thought maybe you could comment on, beyond housing, what are the partnerships that you most look for as you're making policy changes? You talked a lot about convening. Mm-hmm. Who do you quite often find convening, that you are convening?
Well, I think it's a really good question, because it reminds me not only of sort of system integration, but also culture change. I mean, these big bureaucracies and institutions are quite siloed, and it's not necessarily intentional. But when you have, tens of thousands of folks trying to do the business of the state of California, it's difficult for our Human Services Agency to meet with the BCSH secretary and the transportation secretary and our food and ag secretary, right? Like, just being able to come together and talk about how our work intersects, how we might collaborate and align some of the common sense, right? Like, I think some of the human-centered focus approach allows us to shift some of the cultural norms around, I don't do that part. That's Suresh, that's your thing. So I think part of it is just, how do we look more holistically at the way that we are trying to service the consumer, the customer, the client, the patient, and then bringing folks together to say, it's actually not it's almost like it's extra to coordinate. It's like, oh, that's like a soft thing. That'd be nice to have. But I actually think it's central to the way in which people are served in our communities. And so as I heard your question, I was thinking about how we were trying to get folks to screen when someone who was unhoused came into the emergency room, and there would be an assessment, and there wouldn't be any questions about housing or their jobs, or so how do we think about like that holistic care, and then shifting our culture that we are not so siloed and so busy that we can't come together and think about the person's needs and adjust our systems accordingly. And so that's what I get excited about. I know it's hard, but we have some really great examples. Prop 1, which many of you all know, just passed, which is our MHSA reform at the state of California. So our Human Services Agency is doing a lot of work on that part of the house. And we, of course, are doing the work on the housing side of the house with our bond funds. But I'm like, it's the same people that are needing the behavioral health services, those who are experiencing homelessness that need to be housed. So why don't we think more strategically about what kind of delivery of service we're going to do? So we actually have an interagency task force that has come together under the governor's direction to make sure that we are not only aligning, but we're integrating. And I think that that's a really important cultural shift for all of us.
And I'll just do a pitch for research. I turned to Suresh and said, that's a care coordination question. Why don't you take it first before I take it? But it also really highlights to me an incredibly valuable role that research can play in improving the care that you just highlighted so nicely, which is, a research question when I heard you talk was, what are the predictors for a particular child of needing the services that you describe? Do all kids really need all of those services, or are there some children that need 3 of the 7 services that you just listed? And how can we identify them to make that visit as most efficient as possible and have a really effective care model? A research question could be, let's talk to the families that you're talking about and understand what's their experience of that very complex navigation of that care system with a very ill child. And researchers do that, and then that can really inform the clinical care. So I want to activate people in this room to think about those kinds of questions. Those are research questions and research projects that can directly tie to improving care here at UCSF Health and other places.
Great. We don't have time for any more questions. We could, but I think it's after 4, and I think we have to respect our speakers' time. I want to thank you all, for honored speakers, for taking the time to speak with us today. And I also think this has been a wonderful opportunity to break down some silos and think about healthcare and community engagement and policy, and hear each other. And really, I think that with our workshop and with the work that we have to do in our Clinical and Translational Science Institute, writing our grant renewal in the next year, that we're going to take some of the lessons learned today, and I think they'll be incorporated. I can't promise anything, but I think they will. And I am really encouraged to hear that our leaders here at UCSF and at the state really seem to have our backs in terms of really wanting to make our research count and really wanting to make it possible for us to work together across multiple disciplines. So thank you very much. Thank you very much for all of you who came and spent the day with us. I really appreciate it, and I know that Dr. Seligman and Dr. Schmidt appreciate it equally, as well as all of us at CTSI.